who are joining on Periscope all around the world. We are live with the residents of St. Luke's Roosevelt, Beth Israel Deaconess Medical Center. I guess it's not Deaconess anymore, isn't it? Is it just Beth Israel Medical Center?
Well, you're right. You're right. You're right.
Beth Israel Deaconess. All right, so I'm just going to set it up. For any of you that have Periscope right now, if you can, Rifat or Emilio, if any of you can check to see if the screen is showing well on the Periscope. Yes, on Periscope. And I'll give a little bit of an intro before we actually get started. We're aiming to get started exactly at 8 o'clock.
Can you hear us?
Hi, Sanjay.
Hi, Ola. How are you? Welcome to our session. Can you hear us?
Yes, I can hear you.
Can you see the screen?
Yeah, now it is better. You have to adjust the screen, Sanjay.
Adjust it a little bit more.
Okay. Yes, we can hear you and see.
Hear and see both.
Yeah,
Okay, great, Ola. That's perfect. So you guys can ask questions. So this is Dr. Elzamar from SUNY Upstate Medical University in Syracuse, New York. So their residents are also attending live, Rifat and Emilio. So they're attending live along with you. And Dr. Paul Andres is also attending from New York City from the VA. And several other people are joining in now on Periscope, so that's great. And we are going to start this slide seminar now. Ola, are you guys ready? Your residents are there?
Yes.
Okay, great.
So we have 4 more sites which are always connected, so we just have to just check whether we are connected.
Okay.
VI and Roosevelt, are you guys there?
Ola, hang on while everybody gets connected and we'll start in about a minute.
Okay, no problem.
Okay, thank you. Good morning to all the SUNY Upstate residents.
Good morning. Good morning.
Okay, great. Thank you for coming, you guys. I know that you had a different talk, and I really appreciate Dr. Elzamar's arranging this, and you guys attending this. Hopefully, you guys got to preview some of these slides.
Right.
All right. The good news for you is that I'm not going to pick on any of you, so you can just sit back and enjoy. Isn't that the best of both worlds? So all the pressure is on the St. Luke's residents to get stuff right. But don't worry, this is not going to be a malignant thing. It's going to be very laid back and relaxed. Very laid back and relaxed. Some of these cases are very hard. So don't be worried if you get it wrong. I mean, the point of the thing is to show some hard cases, some easy cases, just a mix of both.
No, so Sanjay,
Yes.
before, are you starting now? I would like to give a little bit of intro.
Okay, sure. Go ahead, Rifat.
So we are almost 8, so we can get going. So good morning, everyone. Good morning, Sanjay, and all around the world, or whoever are joining us. You are all welcome. So I would like to give a brief intro about Sanjay. Now, whoever is joining, so they know him well. So Sanjay, despite just we have been good friends for quite some time, so but still, I would like to give an intro about his professional credentials. So you all know that he is attending at Cleveland Clinic in Cleveland, Ohio. Just a little bit of highlights about his professional attributes. So he is the author of the lung pathology textbook, which was recently released at ASCAP. So which was published by non-neoplastic pulmonary pathology and algorithmic approach to histologic findings in the lung. So the book will be released worldwide very soon. I am sure it's going to be a great one. I had the chance to have a look at it early on, so I already got it. So it should be a great one. I am excited to read it now. So he has been invited faculty speaker for ASCAP long course in pulmonary pathology in 2011. He was also a faculty speaker for ASCAP short course in 2015. He is the section editor of pulmonary pathology for the editorial board of Archives of Pathology. He is also a member of the abstract review committee for ASCAP since 2009, and he is also a member of the abstract review committee for CAP and a lot of others. So Sanjay did his med school from Maulana Azad Medical College in Delhi. So after that, he did the pathology residency at All India Institute of Medical Sciences in New Delhi. That's where I met him. And later he did his pathology residency here at State University of New York, Upstate. And then he went on to do his pulmonary pathology fellowship at Mayo Clinic. And so he has won a lot of awards. So I just want to name a few. He has got the award for excellence in pathology teaching at the New York Upstate University. He has got certificate of appreciation as the best teacher in pathology residency program in 2008. And he has got a lot of other awards as well. And he has published a lot. He is very well published. He has been a great teacher and a great mentor. So he has got a lot of publications, around 100 to name. So without much ado, Sanjay, it is to you now.
Thank you very much, Rifat. That's a very generous introduction. Thank you all for coming, the residents of St. Luke's Roosevelt, the residents of SUNY Upstate Medical University, and all the pathologists who are watching worldwide. We are potentially here doing an extremely novel and cool thing in terms of using social media for teaching worldwide on this Periscope app. So I'm really, really excited, and thank you for having me. One disclaimer I'd like to make right now is that we are not going to use any specific patient information on any of these cases. So all the information that I give you is potentially fictitious, and obviously we're not going to use any information that could be, individual patients could be identified. So we are going above and beyond in terms of patient privacy here, and we will not use any identifiable information. I'd like to thank Rifat for inviting me. I'd also like to thank the people who helped me to set up this talk. It's taken a lot of coordination. Dr. Kegel, who's the editor-in-chief of the Archives of Pathology and Lab Medicine, and is spearheading social media talk. The use of social media in teaching. Also, Dr. Ola Alzamar at SUNY Upstate, and Paul Andres, who's the chief of pathology at the VA in New York, for helping me to coordinate multiple people watching at the same time. Dr. Natasha Reckman from Memorial Sloan Kettering for helping to spread the word. And finally, I'd like to mention Maren Fuller, who I met on Twitter along with several of you other pathologists, who has really, along with Jared Gardner, started this the application of Periscope for teaching pathology worldwide. So my idea came from a talk that Jared gave on the use of social media, and he also used Periscope to video and archive that. And Maren Fuller is really the technical brains behind the operation. I'd also like to thank Renee Slaw and Scott Mackey, who are our technical folks here at the Cleveland Clinic. So how this will work is, as you know, the St. Luke's Roosevelt Beth Israel Medical Center pathology residents are watching live on GoToMeeting. The SUNY Upstate residents are also watching live on GoToMeeting, and a few pathologists elsewhere in the United States are also using GoToMeeting to watch live. So that's the traditional way of video conferencing a talk like this. But the interesting thing is that many other people worldwide will join and watch live on their cell phones using the Periscope app. So this is potentially the first time that a lung pathology talk has been done this way. Potentially any pathology talk has been done this way ever. For the people who are watching on Periscope, you can watch live video and hear me. Those of you who are already on know this. But I cannot see and hear you. So I'll repeat that. I cannot see you or hear you, but I can read your comments, although my phone is horizontal, so it's a little difficult to read. But I can see that you joined. For example, I can see, because MVMD joined, I know that Maren Fuller already joined this talk. And so as you join, your name pops up on the screen, and as you like the talk, little hearts float up on the Periscope app. So I know that way that you guys are watching. So that's how Periscope works. In terms of how this talk will work, I'll quickly have a St. Luke's resident describe the pathologic findings. We'll have a little brief interactive discussion using digital slides that we've scanned here at Cleveland Clinic. I'll show you the diagnosis, and we'll do very briefly the take-home teaching points, basically one PowerPoint slide. And for a few other entities, I'll show you a few more interesting slides. And at the end of each entity, I'll give you one nice reference that you guys can use for reading about the topic later if you're interested. Does that sound good? Sound good, everyone?
Yes.
Okay, great. So let's take it from here. These are the times that people are watching in other parts of the world. So for example, people who are watching from India, it's 5:30 p.m. Those watching from Turkey, it's around 3. People who are watching from Spain, it's around 2 o'clock. So this is really a potentially very exciting and novel thing that people can watch this talk free from various parts of the world. So I'm going to get rid of this now and come to our case. So for the first case, I'm going to pick on Sham. If you can tell me what you're seeing, Sham, in this case. So this was case 1. What was the history that you were given here?
Young adult with suspected pulmonary embolism.
Yes, young adult with suspected pulmonary embolism was the history. And I'm starting with this slide, Sham. Why do you think I gave you this particular view? If you can see, can you see the images clearly on your screen?
Yeah.
Why do you think I gave you this view?
I mean, I guess you can see the relationship of bronchial, you can see cartilage, and some other respiratory elements as well. And so I think that you're trying to show that this is kind of proximal as far as anatomy goes.
Okay. Yeah, so go ahead and give me a brief description in maybe 30 seconds of what you saw.
And so I guess in the artery, in the pulmonary artery there, it looks like there's a hypercellular area that's kind of surrounded by this eosinophilic acellular area, so that could be fibrin. And on higher power, see that it's a spindly tumor. It looks like it's architecturally in intervening fascicles. And on higher power, so the cells are, the nuclei are round to oval, and they, I guess there's some elongated cells as well.
Sure, absolutely. So did you have some sort of a thought process as to what this could be? You're absolutely right. So there's something within the artery, and the cells you've described, the description is absolutely spot on. So what was your thought process about what this might be? Very quickly.
So I guess, two ideas came to mind. Well, I guess this looks like a sarcoma.
Mm-hmm. Very good.
And then I guess one idea could be that it's metastatic, or the other idea is that it's primary.
Right. So either metastatic or primary. So that's really a good start. So thank you, Sham. You did a good job there. So, that was our thought process too. We thought, is this a primary or metastatic sarcoma? And we worked it up appropriately. So I'll tell you that in terms of immunohistochemical stains, that pretty much everything was negative. Keratins were negative. All specific markers for that you would do in any kind of sarcoma were negative. There was a little bit of Desmond positivity, focally, very focal, and there was a little bit of smooth muscle actin positivity, so SMA. And I see that some people on Periscope are already suggesting the correct diagnosis, and I can read that because they're typing in their comments on the text section. So, except for a little bit of Desmond and a little bit of smooth muscle actin, there really wasn't any staining with anything. This was a keratin negative tumor, and all specific markers were negative. So the thing I'm trying to show you, as you correctly pointed out, is that this lesion is within an artery. And so the one slide I gave you was a Movat pentachrome stain. And the Movat pentachrome stain, what it does is that it shows you really in very nice detail. For example, here, it shows you the bronchial wall, and you can see that the cartilage is green, and the bronchial cells here with the bronchial mucinous glands. So you know clearly that this tumor is entirely within the pulmonary artery. And that really is the key to the diagnosis here. Very few tumors present entirely within the pulmonary artery and not elsewhere. Notice that this is not really within the wall, it's mainly within the lumen. So that's really what I wanted to show here, and that's why I gave you the Movat pentachrome stain. This stain is very nice for highlighting the architecture, the elastic architecture of tumors. Can you see it here on your screens? Can you guys see it? So this is a Movat pentachrome stain. The collagen stains yellow on this stain. Other kinds of matrix stain green. But it combines, it's sort of a combination of the Masson trichrome and an elastic stain like you would get with an EVG. So it shows you multiple things. So what is the diagnosis here for an undifferentiated sarcoma, which is basically what this is? It's an undifferentiated sarcoma within a pulmonary artery. So what name do we give this thing? So let me show you a couple of pictures here, because the growth was really quite amazing. So can you guys see the growth now? Do you see the growth clearly?
Yeah.
Okay, so this was in the periphery of the lung, and you can see there's a lesion here that is white, and the rest of the lung is brown. So this white lesion was in the periphery of the lung, away from the tumor, in the region that's draining the circulation. And again, you can see this white lesion. It's pleura based. That up there is the pleura. And you can see this is the histology of that lesion. So this is actually an infarct. This is a pleura-based infarct, which is not surprising considering that this lesion is completely blocking off the pulmonary artery. And this is really where the growth gets really spectacular. You can see that there's a bronchus there. You can see how the bronchus branches. And within the pulmonary artery, there's a lesion that is completely blocking off the entire lumen. So Sham, you were absolutely right in how you described it. This lesion is intraluminal and affecting the pulmonary artery. Here's the unaffected bronchus next to it. And you can see that on your arrows. Now you see another section of little pieces of lung. Even distally, as the arteries get smaller, you have a bronchovascular bundle with a bronchus and then the partner artery, and wherever you have a partner artery, the artery is completely clogged up with this tumor. This is very characteristic, and this is why these patients typically present with pulmonary embolism, is because these really are a kind of emboli, except that these are malignant emboli. So I'm going to talk to you about this lesion, but before that, I'll just talk to you about sarcomas that arise in the pulmonary artery. So the vast majority, which is the majority of the circle here, the vast majority of sarcomas that arise in the pulmonary artery are so-called intimal sarcomas, meaning that they are sarcomas that presumably arise from intimal cells, although I'm not sure that's necessarily true. But they have been assumed to be so because they are mainly within the lumen, they're not really within the wall. And a small proportion of pulmonary artery sarcomas are sarcomas that arise presumably within the wall, and those are called mural sarcomas. So a sarcoma like this would be an intimal sarcoma mainly because of the growth location, not because of any specific histologic feature. So this would be an intimal sarcoma. And what kind of sarcoma is an intimal sarcoma? Well, the vast majority of intimal sarcomas in the pulmonary artery are actually undifferentiated sarcomas, or things that you would have called MFH in the past, and you would call undifferentiated pleomorphic sarcoma in the current day. So our case, I think, fits into this kind of a lesion. It's just an undifferentiated sarcoma that is arising in a luminal filling fashion in the pulmonary artery, and so is the pulmonary artery intimal sarcoma. I will mention that you can get differentiated sarcomas also in the pulmonary artery, like leiomyosarcoma or rhabdomyosarcoma, angiosarcoma, osteosarcoma, and chondrosarcoma. But those are the minority, and different papers have different proportions of the two. Interestingly, you can also get intimal sarcomas in the aorta and in the heart, also in the inferior vena cava, and they are also called intimal sarcomas if they predominantly fill the blood vessel rather than being in the wall of the blood vessel. So the diagnosis in this case is intimal sarcoma of the pulmonary artery. It's very common for these patients to present with a pulmonary embolism and to be treated with Coumadin till eventually the clinician recognizes that the Coumadin is not helping the patient and that this lesion is actually growing instead of shrinking or disappearing. So intimal sarcoma of the pulmonary artery. The one paper that I would recommend for you guys to read is this from Alan Burke and Renu Virmani from 1993, which really introduces the concept of an intimal sarcoma of the pulmonary artery. All right, any questions, guys? Have you guys seen an intimal sarcoma of the pulmonary artery before? No, it's an extraordinarily rare diagnosis, but it's nice to know that this happens. And anytime you get an embolectomy or a thrombus removal from somewhere, make sure to look for tumor so that you don't miss a diagnosis like this. Any questions from the St. Luke's folks?
So do we need to rule out a mass as well? So we actually thought of this diagnosis like that, yeah, it can be a pulmonary intimal sarcoma.
Right.
That was the first thing in our mind. But with the history, I just gave the history that pulmonary embolism, so that is the classical presentation,
yes.
I guess, that pulmonary intimal sarcoma, right?
Yes.
And so do we need to, on this morphology, like, we need to rule out metastasis like maybe the patient had a soft tissue malignancy somewhere else, and we are looking at it.
Yes. Yes. So the question is, should we be thinking about a metastatic sarcoma in this setting? Certainly, if you have a small biopsy, or if you don't have the clinical history, or if the patient has a history of sarcoma elsewhere, certainly you should be thinking of a metastatic lesion. In most cases of internal sarcoma of the pulmonary artery, it is so obvious that the bulk of the mass is within the pulmonary artery that clinically it is seldom a problem whether this is a met or a primary. It's more in our minds we have to think, well, could this be from somewhere else? So my answer would be ideally yes. You should talk to the clinician and tell them look for a metastasis from elsewhere, but in most cases it's pretty obvious that the primary lesion is within the pulmonary artery. From the clinical point of view, the question usually is this malignant or is this benign? Not really where is it arising. Is that clear, Rifat? Did you get that?
Yeah.
Okay, Ola and the folks from SUNY Upstate, any questions?
Oh, we're all set. Thank you.
Was that clear? All right, so let's move to the next case. This one is being presented by Wenjing. All right, Wenjing, we're going to case 2. And what was the history that you guys got here?
So the patient is a young dog with lung nodule.
Lung person with a lung nodule?
Young adult, yeah.
All right. So I'm going to bring the images up on image scope, and then I'll let Wenjing describe what she saw. So at low magnification, what do you see, Wenjing?
So I see and the pretty demarcated the nodule.
Yes.
And surrounding around.
Surrounded by lung parenchyma. Yeah, that's right.
And within the nodule, we see some area of hemorrhage.
We see areas of hemorrhage. Yes, that's right.
And if you go a little bit high power.
A little bit high power. Okay.
So here we can appreciate that it's like spindle-like neoplasm.
Spindle-like neoplasm. Yeah, forgive me for repeating everything that you say, but I'm repeating it for the Periscope audience in case they can't hear you. So yes, go ahead. Spindle cell neoplasm.
And it formed like a short fascicle, and also some areas we saw before is a little bit like storiform.
Short fascicles and with a storiform pattern in some places.
And
Yes.
another thing, we have seen together, we saw some inflammatory cells within the spindle cells.
Inflammatory cells. Very good. So what kind of inflammatory cells did you see in there?
See, predominantly it's a plasma cell, but we also see lymphocyte.
Plasma cells and lymphocytes. So let me just highlight that because it's a little bit far away for the Periscope audience, but here's a group of plasma cells within the lesion, and here's a small cluster of lymphocytes. But the vast majority of cells, like you described, are simply just spindle cells, correct?
Yes.
Now, are these spindle cells, Wenjing, are they very malignant looking? Are they pleomorphic, and do they strike you as a high-grade lesion?
No, it's pretty bland.
It's pretty bland.
Has a lot of cytoplasm.
Yes. I love the word bland because that's one way to say that you think it's benign looking without actually using the word benign. So it's a very nice way to describe something. Cytologically bland. Do you agree with me that it's cytologically bland, this lesion?
Yes.
Yes. Okay. All right. So Wenjing, you did a great description. So tell me, what was your thought process? What could this lesion be? What's your differential diagnosis?
So we have differential. The first, on top of differential will be inflammatory, the myofibroblast tumor.
Inflammatory myofibroblastic tumor. Very good. Actually, I see now that on Periscope, some people are guessing the same thing. IMT, somebody said. Okay.
Yeah.
Anything
and,
else?
Our differential also has the solitary fibrous tumor.
Solitary fibrous tumor. That's right. Most solitary fibrous tumors arise on the pleural surface, but certainly they can arise within the lung too, perhaps from invaginated pleura. So that's a good thing to think of. Yes. What else?
Yeah, and also the least we saw probably is it can be like synovial sarcoma.
Synovial sarcoma. That's a good thought, although I will mention that most synovial sarcomas look bluer than this, and they are overtly malignant. So, when you look at that, you think, is this some sort of a blue cell tumor slightly spindly blue cell tumor, and they tend not to be so bland. But that's a very good thought. That's a good thought to include that in your differential diagnosis. So given that inflammatory myofibroblastic tumor was your first differential, what stain would you like to see? What would be a really nice stain to confirm that?
It will be ALK.
An ALK stain, right? Okay, so I'll show you the ALK stain that we did in this case, which is like the garden variety ALK 01 stain. So what do you think, Wenjing? Is that positive?
I think it's positive.
Check out the lung next to it. So it's kind of hard to read, isn't it? Will you give me that? It's hard to interpret whether this is positive or not. Maybe very weakly positive, like a faint blush. Let me just take it to higher mag. Maybe a faint blush of positivity. So this is the standard ALK stain. I'll show you now another version of the ALK stain, which is the ALK D5F3, David 5, Frank 3. D5F3. Do you guys know what the D5F3 ALK antibody is? Anybody at St. Luke's? What is the D5F3 antibody used for in lung pathology? Anyone?
No.
So, when we have ALK positive adenocarcinomas in the lung, instead of using FISH, we screen using the D5F3 antibody, and that is a surrogate for FISH positivity in ALK positive adenocarcinomas. It's a very ultra sensitive kind of ALK antibody. So here I'm showing you the D5F3 FISH, the D5F3 antibody, just to show you the difference between the D5F3 and the standard ALK antibody that you use for lymphomas, for example. And you can see here that is very strongly positive in the tumor cells. Do you guys see that clearly?
Yes.
Yes, so Wenjing, your diagnosis was right, and your differential diagnosis was correct too. So this is actually an inflammatory myofibroblastic tumor, which is ALK positive very weakly by the standard antibody, very strongly ALK positive by the D5F3 ultra-sensitive ALK antibody. And we also did FISH, and we confirmed that it was also had the break apart ALK FISH by that modality. So that's the correct diagnosis. So the point I wanted to make here is this is also quite an unusual tumor, but is actually one of the commonest tumors when you look at young people. So that's the correct diagnosis, inflammatory myofibroblastic tumor. So think about that whenever you see a lung nodule in a young person. That's basically what you need to do. Whenever you think of a lung nodule in a young person, along with other things like carcinoid tumors, and other benign lesions, inflammatory myofibroblastic tumor is one of the most common lung lesions when you think of lung nodules in young people. It's a combination of bland spindle cells and inflammatory cells, exactly like you described. And like you said, plasma cells are one of the common cells in this tumor in terms of inflammatory cells. Most cases are positive for ALK by D5F3 and by ALK FISH, but there are the so-called ALK negative inflammatory myofibroblastic tumors, and people have started to try to figure out what those are. So the one reference I'm going to show you is this paper that recently came out from Memorial from Cristina Antonescu's group. Dr. Al-Almadi, who is also on Twitter, one of the pathologists who's on Twitter, is part of that, and Dr. Travis and Fletcher are as well. And that paper essentially shows that although the majority of IMTs have ALK translocations, there are also some that do not have the ALK and have rare things such as ROS and RET. So there might be inflammatory myofibroblastic tumors that do not have the ALK translocation, but in my experience, in the lung IMTs, most cases do have the ALK antibody. So it's a useful thing to use. All right, so that's all for this case. Any questions from the St. Luke's folks? Any questions, Rifat, about ALK?
Actually, we kind of, as you said rightly, that we all agreed that we were looking at a benign lesion. So it's nice we hardly see inflammatory myofibroblastic tumors in the lung.
Yes. Yeah, it's just an uncommon entity. Yeah. Go ahead.
Negative IMT. Yeah, because I think there are reports that L negative IMPs are having worse prognosis than L positive IMPs. Is it true?
Yeah, the problem with the literature is that the inflammatory myofibroblastic tumors that are described are from all sites, so it's not just lung, it's from all sites. So it could be that some of the prognosis is site dependent, some of it might be size dependent, some of it might be histology dependent. I'll tell you that when you have a bland histology like this, and when you have a lung IMT, most of them have a benign behavior. So it's very unusual to get an IMT that behaves badly and is a primary lung IMT. Okay, any questions from the SUNY Upstate folks? All clear? Okay, all right, let's move to the next case, guys. So this one will be described by Emilio. Emilio, can you take case 3?
Sure. So case 3, the history gave us an elderly adult smoker with a lung nodule.
Elderly adult smoker with a lung nodule. Yeah, this is quite a difficult case. So I apologize for giving this, but I think there's some useful stuff to be learned from this. Yeah, take it away, Emilio.
So, yeah, I mean, with that history, smoker, the first thing that comes to mind is some neuroendocrine something, just because of the smoking association.
Sure.
So we have here like a well-demarcated lesion with some areas that kind of look, trabecular up at the top. It looks a little more solid, but yeah, this area might even have some
trabecular architecture. Yeah, sure. Mm-hmm.
And you have like a pretty new-looking tumor, and in other parts, like on the opposite side of this, you have found some areas of necrosis that look very communal-like.
Areas of necrosis. Okay, fair enough. So, what was your thought process, Emilio? From the H&E, is this a carcinoma or sarcoma, melanoma?
Yeah, so I mean, given the findings and just the morphology of these cells, I'm thinking that I'm in the neuroendocrine category, and the fact that I don't see like just outright like huge areas of necrosis, and it's very much like communal like necrosis, not in this area, but in some of the other parts, and the fact that there are just wall-to-wall mitoses, it kind of puts me in the carcinoid portion. So not the high grade, like large cell neuroendocrine or small cell neuroendocrine or small cell lung carcinoma. So I'm thinking an atypical carcinoid.
Atypical carcinoid. That was your diagnosis, Emilio? Atypical carcinoid? Yeah.
Yeah, that's where I'm at.
Okay. So did you count mitotic figures, guys? Did you look for mitoses in here?
Yeah, I did, and there it really, KI would have been nice to see, like,
yes.
What that pattern would have been like. If we're above 50%, then yeah, obviously that would push it up to more high grade than, but if we're like more than 20% range. But yeah, I mean, they weren't too, they weren't too present.
Yes. Well,
but it's not, again, not wall to wall.
Yes. We'll come back to that. We'll come back to that in a second. So yes, that's a good description. And then I gave you some immunostains to look at too, right?
Right.
So I gave you a CD56, which is blazingly positive. I don't think we need a high mag there.
Right.
And then I gave you a pancytokeratin, keratin A1/A3, and you can see that it's positive here too. But I want to just point out to you one thing here. Check out this area in the tumor. So we are at high magnification. This is a keratin A1/A3 stain. Why is this portion of the tumor positive and that portion of the tumor not that positive? Or is that positive too?
I mean, could it be that it's
here's a high mag.
Like it's a mixed tumor?
Yes, that's right. That's absolutely right. So why this keratin is showing you two different patterns is because this is actually a mixed tumor. So there is some keratin positivity here, and what the keratin helps you to see is how much cytoplasm is there in this tumor. So wherever you see, a strong blush of keratin in each individual tumor cell, that's because there's a lot of cytoplasm. There's a lot of, cell for the keratin to stain. And where you see only a weak kind of dot-like pattern or a small rim of cytoplasmic staining, why that's happening is because there's the cytoplasm is very scant in those tumor cells. So there really isn't much for there to see. Now let me just outline that. For example, here, there are cells here that are keratin positive. It's just that there's very little cytoplasm, so there's very little for the keratin to stain. On the other hand, the cells here, there is more positivity because there is relatively more cytoplasm. Okay, so before we get out of that, I want to show you one more, which is the chromogranin, which I feel is the best neuroendocrine marker in terms of specificity. And again, you see the same pattern, right, Emilio? So can you describe what the staining is like in those same two patterns? What's going on here and what's going on there?
Right. So yeah, there are areas with stronger staining.
Yes.
We expect it to be with the cytoplasmic stain.
Yes, exactly. And what's going on in that one that I just outlined? What kind of pattern is that of staining, of chromogranin?
Oh, yeah, it's like pinpoint, dot-like.
Pinpoint dot-like. So that's exactly right. So in fact, if you count overall, the mitotic rate is actually pretty high in places. There, and as you mentioned, there are some areas of necrosis too. The mitotic rate is actually more than 10 per 10 high power fields in many areas in this tumor. So I think that this is actually a high-grade neuroendocrine carcinoma. And so that would automatically take it out of the carcinoid group. You're absolutely right to consider an atypical carcinoid, especially if your mitotic count was lower. So in a sense, your mitotic count is very important in a case like this. If it's a high mitotic count, that takes you in the small cell / large cell neuroendocrine group. And if the mitotic count is lower, it keeps you in the carcinoid group. So in this case, really everything hinges, as we can tell, on the mitotic count, right? So my diagnosis here was combined small cell and large cell neuroendocrine carcinoma. And again, that would be the right diagnosis only if the mitotic rate was high and there were areas of necrosis. But if the mitotic rate was lower, the way you describe it, then certainly atypical carcinoid would be the right thing to consider. So the teaching points I wanted to tell you guys here is that you can have small cell carcinomas that are combined with other kinds of tumors, including large cell neuroendocrine carcinoma or adenocarcinoma or squamous cell. They are treated identically as small cell carcinoma of any other kind. So it's really the small cell carcinoma component that counts. And I'll make one really important teaching point here is that when a tumor is biopsied, and when you get, the typical features of small cell, you're much more likely to think of small cell. When a tumor is resected, there's something psychological about that prevents one from even thinking about small cell carcinoma, because you do not expect to see that in a resection specimen. But remember that small cell carcinomas can be peripheral, they can be small, and they can be resectable. So you will occasionally encounter a small cell carcinoma like this in a resection specimen. But this is one of the common settings in which not just residents, but many experienced pathologists even don't think about small cell carcinoma because they don't expect to see it in a resection specimen. The differentiation between small cell and large cell neuroendocrine is purely based on morphology and is actually very subjective. The one paper that I'd like you guys to read is a very nice recent paper by Natasha Reckman that shows you that large cell neuroendocrine carcinomas actually by next generation sequencing break into 3 groups: those that have genomic abnormalities like small cell, those that have genomic abnormalities that resemble that of adenocarcinomas, and a small group that actually have genomic abnormalities of carcinoid tumors. So it's possible that some of these are just very high-grade carcinoid tumors, whereas some are just small cell carcinomas with more cytoplasm, and others are adenocarcinomas that happen to have neuroendocrine features. So this is definitely a difficult case, and you guys did a very good job describing it. All right, any questions about it? Emilio, Rifat, any questions about large cell neuroendocrine carcinomas or differentiating them from atypical carcinoids?
Yeah, this is a very good point. Regarding mitotic count, of course, so we discussed about the mitotic count and the diagnosis in this mitotic count. So we were unable to maybe it looked so high grade number one. And actually on morphology, without looking into the immunos, it really looked like that there were 2 components. We were looking hard that there were definitely areas which look small cell. You have the cells which are very back to back and dark nuclear chromatin. But as you showed on immuno also that definitely we had cells which looked little different, which were larger, prominent nuclei, and they were more pleomorphic. So, but to give a diagnosis of small cell and neuroendocrine combined, so it's kind of very scary. We thought that, okay, how even on immuno it would be difficult to even differentiate. Both will be neuroendocrine marker positive, right?
Yes, yes. So it's a difficult case on multiple levels. And I think that one take-home that you guys should take from that is, even in a resection specimen, right, where you expect to see a neuroendocrine tumor being a carcinoid tumor most of the time, even in a resection specimen, always think about the possibility of a small cell carcinoma in a neuroendocrine tumor. Okay, guys, Ola and the SUNY Upstate folks, any questions on this case?
I just have a question about, was this biopsy before? And if yes, what was the diagnosis on the biopsy?
Very good question, Ola. Honestly, I do not remember. I do not remember if they had a biopsy specimen. I can guess that they didn't have a definitive diagnosis, because if they had a small cell carcinoma diagnosis, this thing wouldn't have been resected. So my guess is they either didn't biopsy or they biopsied and got a diagnosis different than the final.
Yeah, that makes sense.
Yeah, but sorry, I don't remember exactly in this case whether it was biopsied before or not. Good question. All right, so let's move on to case 4. Case 4 will be described by Mallory. All right, Mallory, all yours.
Okay. So,
History on this was probably lung nodule in an elderly individual.
so this patient is elderly adult with a lung mass.
Yes. Okay. Go for it.
So on this cover, you can see a well-delineated area of lesional tissue from normal lung tissue on the periphery.
Yes. Normal lung on the left and lesional tissue on the right. So let me just get to high mag and cut to the chase here.
So on higher magnification, you can appreciate these solid nests of cells that are separated by fibrous septa.
Yes, solid nests of cells. Correct. That's right.
And these cells look pretty pleomorphic.
Pretty pleomorphic. So clearly malignant, isn't it? Yes.
Malignant.
What kind of malignancy do you think it is?
Probably like epithelial tumor.
What's that?
Epithelial.
Epithelial tumor. So what do you call a malignant epithelial tumor? In one word? Carcinoma, right? Okay. Well, and then take it one step further. So what kind of carcinoma? Is it small cell or non-small cell?
Non-small cell.
Non-small cell. And that's because it has so much cytoplasm. These nucleoli are so big. So there's no question about it. This is clearly a non-small cell carcinoma. The question really is, what kind of non-small cell carcinoma is this? Is this adenocarcinoma or squamous cell carcinoma? So let me ask you a different question. Was it easy to tell, or is it difficult to tell in this case, whether it's adeno or squamous?
I think it's difficult to tell.
It's
But it looks more like squamoid, but I feel like you can't just rule out adeno.
Yes, so she said it looks a little bit squamoid, but you can't rule out adenocarcinoma. So what you're telling me, Mallory, is essentially you're not sure, right? Is that fair to say?
Yeah.
And actually, I wasn't sure either. And that is what we call nowadays a poorly differentiated non-small cell carcinoma. So that is a non-small cell carcinoma where by standard morphology, where you would be able to see glands or keratinization or intercellular bridges or papillary or micropapillary architecture, you cannot see any one of those features clearly. Now, is there a hint that there might be glands here? Maybe. So that might be a lumen and a gland. Can you guys see what I'm circling? Do you guys see that clearly? Okay, so let me show you another. Maybe that is a lumen. Who knows? Maybe that's a little hole. Maybe that's an artifact. So when you get a cancer like this that is clearly non-small cell, but you can't tell for sure whether it's adeno or squamous, what's your next step, Mallory? What do you really want to see?
So I wanted to do immuno.
Immuno. So what immuno would you like to see first?
So I would do probably an Opsin or TTF1.
Okay, so let me show you the TTF1 first. And what does it show?
So it's strongly positive, diffusely positive.
Is that helpful?
Yes.
Yes. So what would your diagnosis be at this stage? What would you call it?
So you think adeno?
Yes. You could call it poorly differentiated adenocarcinoma, which is what I do. Or you could say poorly differentiated, non-small cell carcinoma, favor adenocarcinoma, which is how the WHO likes to do it. But case closed, right? Or is it closed? Let's see. Is case closed?
No.
No, because you also want to see the other stain, right? You want to see P63 to see whether it might be squamous. So what's going on here, Mallory?
So you still have some positivity here as well.
There's some positivity, right? Is it 100% of cells strongly and diffusely positive? No, it's not 100%. It's patchy. Some of the cells are strong, some of the cells are weaker, many of the cells are negative. So what do you do now? I mean, the same cells are TTF positive and the same cells are also P63 positive. Is this just a tumor that can't make up its mind?
No, so I think you would, I wouldn't still use that. I would still want to do another stain. Maybe a mucin stain.
But if you just had those two and you didn't want to do anything else, how would you interpret a tumor that's both positive for TTF and P63?
Well, I know in adeno also you can still have P63.
You can have P63. Can you have that kind of diffuse TTF1 in a squamous cell carcinoma?
No.
No.
Not usually.
So your diagnosis is done, right? This is a poorly differentiated adenocarcinoma that just happens to have P63 positivity, right?
Right.
Right. So that's how I would interpret it. But nowadays we have another marker that really helps us for people who are skeptical, because I can see that some of you are skeptical just from your expression, right? I can see that you are skeptical. For that we have another marker, and that's called P40. So what's the P40 doing here, Mallory, in this tumor?
So here it's negative, but you still have some cells that are picking up.
Rare cells, right? They're rare, weak, positive cells, but the vast majority of the tumor is P40 negative, correct? You could also do, on the adenocarcinoma side, you could also do a napsin stain. And did you guys get that immunostain? Did I give you that?
Yeah, we had it.
So Mallory, what's going on here with the
So
napsin?
here it's strongly
Yes. So
positive.
this tumor is strongly and diffusely TTF and napsin positive. It has patchy P63 positivity, and it's basically P40 negative, right? So I wanted to show you this case just to show you how the immunostains work and to make some basic points about, was this case 3 or 4? This was 4, right? Yeah. So the diagnosis here is poorly differentiated adenocarcinoma. But the point I wanted to make is there are 2 points that are important for subtyping when you subtype a poorly differentiated carcinoma like this. First is that TTF trumps P63. In other words, when you have a tumor that is strongly and diffusely TTF positive and has patchy P63 positivity, that is an adenocarcinoma, not a squamous cell carcinoma. And also it's not an adenosquamous cell carcinoma. Secondly, P40 and P63 are equally sensitive for squamous cell carcinoma, but P40 is more specific. And by that what we mean is that P40 will stain a far fewer proportion of adenocarcinomas than P63 does. In other words, getting false positivity with P40 is very, very rare, and it's therefore a more specific stain. And in many centers, including ours, when we have a limited biopsy, we prefer to use P40 over P63 nowadays. So our panel for subtyping when there's very little tumor and a small biopsy is TTF and P40. That's what we do. So is that clear to everybody why this case is an adenocarcinoma and not a squamous cell carcinoma?
Yep.
Yes. Any questions from St. Luke's? Did everybody?
Yeah, we should.
Yeah, go ahead.
We still do we have, so suppose we want to call it a solid variant of adenocarcinoma or something.
What's that difference? Repeat your question, please.
So do we need a mucin stain still?
We don't.
Just in case?
No, so the mucin stain has become, archaic at this point. It's become outdated because of immunohistochemistry, because the TTF and P40 are so sensitive, and so specific in specific situations. There is hardly ever, almost never a case where a mucin stain will show better performance than these two stains. Now, if you have obvious mucin in a tumor, you know, if you have a mucinous adenocarcinoma, you don't even need stains. You don't need a TTF-P40, but you don't need a mucin stain either. So really, there's really no need to do mucin stains in any situation for subtyping in the modern time.
Yeah, no, I think this is a good case in the sense that, I mean, if we are not aware of the fact that co-differentiated adenocarcinomas can be P63 positive and rarely P40 positive also,
yes,
we might be repeatedly leading towards calling it adenosquamous and think that, oh, we have both adeno and squamous markers positive and it's an adenosquamous.
That's right. That's a great point. That's a great point. So remember, for everybody watching, just because you have a little bit of P63 positivity in an otherwise strongly and diffusely TTF positive tumor, it does not mean that that has squamous differentiation. That just happens. It just happens that you can have a little bit of P63 in adenocarcinomas. Great point, Rifat. Any questions from SUNY Upstate?
No, we're still using the P63 though.
Still, yeah. And I think, you know, there's absolutely nothing wrong with the P63 as long as you know how to interpret it, especially if you know that TTF trumps P63 in difficult situations. We have shifted to the P40 here mainly because of, you know, because it makes life a little easier than P63, but there's absolutely nothing wrong with using P63. It's just, you need to know how to use it. So that's a perfectly valid point.
CK56 also.
Yes, great point. So, you know, in the paper we did from 2011, CK56 was also used as a marker of squamous cell carcinomas. Personally, I find that if you rely on the CK56 alone, you can get into trouble for subtyping. So I never use CK56 alone in the absence of P40 or P63 to make a diagnosis of squamous cell carcinoma. In other words, my paradigm is if a tumor is not diffusely P63 positive or P40 positive, that is not squamous cell carcinoma. I use that now as almost like a definitional thing.
Okay, thanks.
Yeah, thank you, Ola. So the paper I want you guys to look at is this paper from Justin Bishop and Natasha Reckman and also Dr. Pelosi from Modern Pathology that shows that P40 is superior to P63 for the diagnosis of squamous cell carcinoma. Although, as Dr. Elzamar mentioned, there's absolutely nothing wrong with using P63 as long as you know how to interpret it when both TTF and P63 are positive. All right, guys? Okay, so I think what we'll have to do is we'll have to abridge and do maybe one or two of the remaining 4 cases so that we can stop at 9 o'clock. But let's take case 6. How about that? So Amar, you want to do case 6?
Amar, can you hear us?
Yes, I hear you.
Okay, so let's do case.
Adults with intestinal neuropathy.
What's that? I'm sorry. What? I couldn't hear you.
Okay, so case 6 we have adult with intestinal neuropathy.
With hilar and mediastinal adenopathy, an adult. All right, Amar. So I'm bringing up the images so you can describe this case. Can I ask you a quick question first, Amar? What kind of biopsy is this? Can you tell from just looking at it? Is it a transbronchial biopsy or a needle biopsy?
Sorry, can I hear you?
So what kind of biopsy is this? Is this a small lung biopsy like a transbronchial or a needle biopsy?
Sure. This looks like a transbronchial biopsy.
It's actually too big to be a transbronchial biopsy. So this is a surgical lung biopsy. And why I put this case in is because you very rarely get to see, not rarely, but uncommonly get to see surgical lung biopsies or what we call wedge biopsies in this particular diagnosis. So this is a surgical biopsy. That means a surgeon had to go in and take this either by an open technique or by VATS to get this piece of tissue. So go ahead, Amar. Sorry for interrupting.
Sure. So there's a section of the lung with the alveolar space, and there is a visit with patchy multinodular distribution of maybe subsequent.
Patchy multinodular distribution. Yeah, that's right.
pink to eosinophilic cytoplasm and the middle of this.
Okay.
That would be adjacent to the bronchial or the vessel in the lung.
Right. And
If you go
so,
on one by one,
yes, yeah. Here's the high power.
yeah, we see, yeah. So we see here there's a lot of circular or like that surface around the big area. There's a lot of lymphocyte, and we see there's some area have giants here or some
Yes,
there.
that's right. So if I ask you, Amar, what is this structure that's in the middle of the field? What would you call this lesion?
This
Right.
looks like lymphocyte. That's
Lymphocytes around the lesion, but this round lesion itself, what is that? Is there a name you can give it?
it's like
This is a granuloma, right? So you've got a granuloma here,
granule structure that one.
right? A granuloma, and then you can see here. I think I'm having difficulty hearing you, but this lesion is a granuloma, and is it a necrotizing or a non-necrotizing granuloma, Amar?
It's not like non-necrotizing granuloma.
Non-necrotizing granuloma. That's correct. So what is the most likely diagnosis, Amar, in this case? Let's cut to the chase here. What is the most likely diagnosis?
So here we think of sarcoidosis as one of the causes of non-necrotizing.
Yes, sarcoidosis is the most likely, right? So the usual, so that's a good description. These are non-necrotizing granulomas within the lung. And sarcoidosis is the most likely diagnosis. In fact, that is the diagnosis in this case. So the reason I put this case here is not to show you non-necrotizing granulomas. Everybody knows what they look like. It's to show you what are the classic features of sarcoidosis that you should be looking out to differentiate sarcoidosis from things like hypersensitivity pneumonitis or hot tub lung or infection. So one thing you should be looking for is the distribution of the granulomas. So if you notice here, the granulomas here follow what's known as a lymphangitic distribution. That is the distribution where lymphatics are found in the lung. So this granuloma here is in the pleura. You can see that little pleura going down there. You can see another granuloma here that is or collection of granulomas that follows the interlobular septum. And how do we know that that's the interlobular septum? Let me just show you a diagram. The interlobular septum is a part of the connective tissue of the lung that invaginates down from the pleura like this. Do you guys see it at St. Luke's? Tell me yes if you do.
Yes.
Okay, so that is the interlobular septum. So as the interlobular septum comes down here, you can see that granulomas are distributed along that distribution. And finally, wherever there is a bronchovascular bundle, so for example, you can find areas where there's an artery here. So next to that should be a portion of a bronchiole that is also involved by granulomas. So this collection of distributions that is along the pleura, the bronchovascular bundles, and the interlobular septa, that is known as a lymphangitic distribution, and that's really characteristic of sarcoidosis. Now the other thing I want you guys to see, which is very characteristic of sarcoidosis, is this fibrosis. Do you guys see it here? The collagen?
Yep.
And it has this characteristic concentric cracked hyalinized appearance. This appearance of the fibrosis is very characteristic of sarcoidosis and is another clue that you're dealing with sarcoid and not one of the differential diagnoses. And of course, the things that you classically know about sarcoidosis, the granulomas should be well formed and they should always be in the interstitium. So in this particular field, let me just point out where everything is. So this here is the air space, so the alveolar space. Let me show you another one. So here, this area is the alveolar space or air space. The granulomas of sarcoidosis are never in the air space. I know very few things are never in pathology, but this is a never. The granulomas of sarcoid are always in the interstitium. So this is a form of interstitial lung disease because the granulomas are here. So well-formed granulomas, interstitial granulomas, concentric layers of hyalinized fibrosis, and a lymphangitic distribution. These are all classic features of sarcoidosis. In a case like this, I'm so certain that this is sarcoidosis regardless of whatever else the clinical features might be, that in a case like this, my diagnosis is non-necrotizing granulomas consistent with sarcoidosis. This is just absolutely classic. And I wanted to share a classic case with you guys so that the next time you see this on a transbronchial biopsy, you have a mental image of a classic case in your mind. Granulomas in the interstitium, pleura, interlobular septa, and bronchovascular bundles, and this typical cracked fibrosis. And another thing that I didn't mention is that lung away from the granulomas in sarcoidosis is absolutely normal, as you would have seen in that case. What reference would I suggest for this? This is a shameless plug for my own book, but I would suggest that anybody who wants to see the classic features, there's some really good descriptors for what you should see in sarcoidosis and what you shouldn't see in sarcoidosis. So that's included in the chapter. Okay, any questions from St. Luke's about sarcoid? Any questions from SUNY Upstate?
When is the book coming out?
So the book is already out in the UK. It's already been published in April, and the book is coming out in this month, in May, in the United States. But it will be it's available already for pre-order from the Cambridge website and from Amazon. But thank you for asking, and all those who have already bought it, thank you very much. So let us go on. Yeah.
We can go up to 9:15 here, or 10 to, yeah.
Can go one more? Okay, let's do one more case. I don't want to hold up everybody, but we can certainly do one more case. Let me pick the most interesting, I think. Let's pick case 7. How's that? So case 7 is Mahabir. Mahabir, are you there? Do you want to present? Case 7?
Mahabir?
Yeah.
All right.
It's an adult with a lung nodule.
Adult with a lung nodule, okay. Sorry, I went a little bit out of the presentation. All right, so here's the lung nodule, Mahabir. Is that the case that you're talking about? And I don't think I gave you guys any stains other than the H&E. Is that correct?
Yeah.
Okay, so Mahabir, what do you see at low magnification?
When we look at the surface magnification, we can see that it's not skewed. There are multiple areas in the specimen. There is what appears to be normal lung, and there are 2 discrete non-encapsulated nodules.
Yes, so normal lung and a well-encapsulated nodule. So Mahabir, let me just point out something here, and you tell me what is that in the middle of the nodule?
Yeah.
What is
pale hypocellular middle center and a hypercellular exterior nodule?
Yes, so he said, yeah, Mahabir, let me interrupt you for a second so people on Periscope can hear what you said. So you said there is a hypocellular center and then a hypercellular periphery. Is that correct?
Can you also say that it is probably necrosis? So maybe you're not hearing it.
Yes, I couldn't hear it clearly, but there's necrosis. Is that what he said?
That's right.
Yes, so that's exactly right. So when I'm backing off, let me back off into this. The center of the nodule is completely necrotic. And then the periphery of the nodule shows this cellular area. So you're absolutely right, Mahabir. Now I'm going to bring it into the cellular area and tell me what you're seeing here. What do you see in the cellular periphery of the nodule?
We can see multiple different cell types in the cellular area.
Okay.
We can see a mixture of multinucleated cells.
Multinucleated cells, right?
Cells.
Right.
Now, we can also see areas of clearing.
Clearing, that's right. Something like this, right?
Areas, we can see exactly multiple small, maybe very variable size structures.
Right. So let me bring it to as high mag as I can and show you. What is going on here, Mahabir? So this is the area you're talking about, right? So it's areas of clearing, and within those areas of clearing you see something. What is that? What do you see in there, Mahabir?
Look at them, we see small, roughly, from the area we have circled to the left of that area, there is a nest of red blood cells.
Yes.
So we have compared sizes, and they're roughly the size of a red blood cell.
That's a very good point. Actually, that's an excellent observation he made. So when you're trying to compare the size of what you're seeing there, the red blood cells are a convenient comparator. So on the left side, you can see how big the red blood cells are, and some of these organisms are smaller, and some of them are about the size of a red blood cell. Very good observation, Mahabir. Yeah, go ahead. So give me your impression. What do you think these structures are?
Because most likely because of the size, the shape, and when we looked at them, we saw some amount of budding, like narrow-based budding. So they're going to be either some sort of cryptococcus or histoplasmosis.
Okay, very good. So he narrowed it down basically to a fungal yeast, and he said it's either cryptococcosis or histoplasmosis. So what is the stain you really want to see, Mahabir? If you are taking your boards, what would be the stain that you would want to see? So there's one stain for the boards and one stain for real life. So what is the stain for the boards? Musicarmin, right? All right, so I'll show you the musicarmin stain here in this case, and let me take it a little bit closer so that you guys on Periscope can see clearly what the stain shows. So this is a musicarmin stain, and you can see that some of the organisms are clearly positive, although not all of them, but some of them have this magenta or pink color, which is how a musicarmin stains in cryptococcosis. So you're absolutely right, Mahabir. This is cryptococcus. If this were histoplasma, would it stain with cryptococcus with musicarmin? Would it?
Histoplasma does not stain with musicarmin.
Yes, so histoplasma does not stain. In fact, if the musicarmin stain is clearly positive, then that pretty much confirms your diagnosis of cryptococcosis. So for the boards, whoever is taking the boards, remember that musicarmin is a great confirmatory stain for cryptococcus. Now I'll turn it around and say that in real life, many times cryptococcus is not positive for musicarmin, and there is such a thing as musicarmin negative or capsule deficient cryptococcus. And in that case, what is the best stain? What is the best confirmatory stain? This is a trick question. St. Luke's, anybody?
Sanjay?
What's that, Rifat? Fontana-Masson? Yeah, that's you could do that. Although that wouldn't necessarily confirm the diagnosis. Here I'm showing you a GMS stain, a Grocott methenamine silver. That wouldn't be the best either, because all it shows you is that there are a number of organisms and there's a lot of size variation. In my mind, the best confirmatory stain for cryptococcus really is the H&E, because that really shows you all the characteristic features of the organism, which is exactly what Mahabir described here. At low magnification, so let's start at low mag, you just get this little bubbly feeling as if there are organisms here in these little bubbly areas. And as you go higher mag into those bubbly areas, you see lots of organisms floating in these bubbles. And these organisms have a gray or light bluish, and let me bring it closer for the Periscope folks, have a light gray or blue cell wall. They often have narrow base budding, and they have this artifact around them, which is a retraction artifact. Some people call it a halo. And really nothing else on H&E has this look that cryptococcus has. So this is really diagnostic of cryptococcus. And as far as I'm concerned, whether the musicarmin is positive or negative, I'll still call this cryptococcus. In fact, this is such a characteristic look that we've also called cryptococcus or favored cryptococcus on frozen section when something was resected and thought to be lung cancer, and they're looking for a quick diagnosis before doing a lobectomy. So this is a very, very characteristic H&E look. And again, I'll make a plug that in the book there's a very good table describing the various differential diagnostic features that separate histoplasma from cryptococcus. All right, so just to briefly recap this, So this is Cryptococcus. The tips are the bugs are visible on H&E. In most cases of necrotizing granulomas that have histoplasma in them, you cannot see the bugs on H&E because they are present within necrosis and they're not visible in that situation. They are only visible in the situation of disseminated histoplasmosis, which in the lung is actually a very, very rare diagnosis. So as I mentioned before, it has a bubbly look at low magnification and it has a gray cell wall with significant size variation. So that's another thing that is for diagnosis of Cryptococcus on an H&E stain slide. And for those of you taking the boards, don't forget about the Mucic-Armin stain. So the way I signed out this case was necrotizing granuloma, Cryptococcus is present. All right, that's all for this case. Any questions from St. Luke's? Rifat at all? Any questions from SUNY Upstate? Dr. Alzamar?
No, we're all set.
Okay. Any questions from Paul Andres? Paul, are you still there? Any questions about the case?
Yeah, we're all still here. No questions. Everything was great.
Okay, great. Thank you very much. So you guys have a choice now. We can do one more case or we can stop here for time. It's up to you. St. Luke's? You want to do one more case? Okay, let's pick on Rifat because he's got away with not doing anything. So let's do case 5 and let Rifat. Let's pick on Rifat. All right. So case 5, Rifat. What was the history on this?
Okay. Case 5 is adult with multiple bilateral lung nodules. Rule out metastasis, rule out infection.
Yes, adult with multiple bilateral lung nodules. Rule out metastasis, rule out infection. So I'll tell you guys, this is the absolutely classic history. For a lung pathologist, it's so classic that you almost think of this diagnosis going into the case. And it's happened to me on frozen section that somebody tells me, hey, look, this is not cancer, but this patient is very suspicious for having metastatic disease. He has nodules in both lungs, multiple bilateral. So I think this is either miliary TB or disseminated histoplasmosis, or it could be a metastatic malignancy. At that point, this diagnosis flashes through my head automatically, even without looking at the H&E. So Rifat, tell me what you saw. What is so characteristic about this at low magnification?
So actually we have 3 pieces of lung tissue that we can see here.
Yes.
This classical on morphology is that we have different lesions at different portions of the tissue. We have some areas which is just subpleural or attached to the pleural surface.
Yes.
And other areas we have just ill circumscribed nodules, like which is more cellular and various areas at various places.
Okay, let me interrupt you for a second. So that is the key. What Rifat just described is the key to the diagnosis. Once you recognize that this lesion is a nodule, you're already half the way to the diagnosis. Right? You say, okay, this lesion is, you think, oh, this is, Dr. Mukhopadhyay is an interstitial lung disease guy. There must be some interstitial lung disease. It doesn't matter as long as you recognize that this lesion is a nodule. So Rifat, let me ask you one more question. Are these nodules round and regular, or are they irregular in terms of outline? Irregular. So this is the kind of shape that is referred to as stellate. S-T-E-L-L-A-T-E. Stellate meaning looking like a star. Low magnification, stellate shape. How big is the nodule, Rifat, if you had to guess? How big is each nodule? Is it a centimeter or smaller?
Yeah, sub-centimeter, I guess.
Okay, let me measure it right here. So here's one nodule, that's 4 millimeters. Let me put another marker on that. So let's do the other one. That is about 3.6 millimeters. Right, so very tiny nodules, aren't they? Multiple tiny bilateral nodules. Okay, and when you went to high mag, Rifat, what did you see within these nodules? What do they contain?
Actually, these nodules are quite cellular, and there is varying cellularity. Like the one that you are showing here is that we can see that there is a lot of interstitial expansion, and which is composed of actually mixed infiltrate. We have some spindle cells, there are some areas which has a myxoid background with some collagen.
Yes.
And there is quite a bit of inflammatory cells. There are many eosinophils. I saw there are some lymphoplasmacytic cells.
That's right.
And there is this groupy, like newly laid spindle cells or something like that. Yeah.
Yes.
And
So
I didn't see any atypical cells.
that's correct.
All were blood-looking cells and a lot of inflammatory cells and a lot of macrophages, alveolar macrophages were there.
Yes. So let me recap that for people who are watching on Periscope. So there's a mixed inflammatory infiltrate in here. And you can see that there are air spaces here. So this is not really an airspace disease. So I'll outline it. There are air spaces, but the air spaces just have a few pigmented macrophages. Those are smokers' macrophages. The pathology is all in the interstitium, and it's exactly how Rifat described. There are these kind of mononuclear cells. There's a lot of pigmented cells. There's a lot of what cells look like fibroblasts. There's just a mixed inflammatory infiltrate. But Rifat, I want you to tell me specifically what this cell is. The one I'm...
Actually, it's like the cell which is kind of wavy, I would say, and a little bit of epithelial looking, and it has a linear groove which is running across the cell.
A linear groove, very irregular nucleus with this kind of brain-like, walnut-like look with a linear groove running across it. What is that cell, Rifat?
I think it can be like Langerhans cell or
a
something like that.
Yes. So what if it's a Langerhans cell? What stain would you want to see to confirm that this thing is a Langerhans cell?
CD1A or a Langerhans.
Or yes, or an S100, right?
Yeah.
Either an S100 or a CD1A or a Langerhans. And here I'm showing you the CD1A stain. So the thing to notice about this is it's not just a few CD1A positive cells. These are sheets and sheets of CD1A positives. That's what you want to see in this disease in the lung. So Langerhans cell histiocytosis of the lung is you get sheets and sheets of Langerhans cells within the interstitium. So that's exactly right, and your description was absolutely correct. So the point I want to make to you guys is the moment you see that low magnification picture of stellate nodules, so let me highlight that again. Once you see these irregular multiple millimeter sized nodules in the lung, you should be thinking Langerhans cell histiocytosis, especially if you've gone to HIMAG and confirmed that there are no malignant cells there. This is just a classic low magnification appearance of Langerhans cell histiocytosis. So let me do a quick presentation on this, and then we'll end it there. Rifat, I think we'll skip the other case, but I want to do this because it just shows, just to communicate the idea to your residents of what Langerhans cell histiocytosis is in the lung. So this is what Langerhans cell histiocytosis looks like. It has multiple tiny bilateral nodules. Rifat, can you see this CT scan on your screen?
Yeah.
Ola, can you guys see it? Is that clear on your screen? Okay, those on Periscope, can you see this clearly, the CT scan? So multiple bilateral nodules, both on the left and the right. Again, you can see here one characteristic thing that these nodules do is there's so-called cavitation, that there's the little black holes within these nodules. And often people, radiologists interpreting that think that is a sign of fungal infection or mycobacterial infection. Now, radiologists, when they see a combination of cystic disease and nodular disease, are trained to think of Langerhans cell histiocytosis. But when they see only the nodules and no cysts, that's when anything can be in the differential, and that's typically the kind of case that is biopsied. So here's a great example of Langerhans cell histiocytosis, and you can see there's nodules here in both lungs. It looks very scary, but you've seen why those nodules look the way they do. There are small interstitial collections of Langerhans cells mixed with other nodules. So you see all these nodules in both lungs. It's a very scary picture, and typically these patients have a malignancy elsewhere, so they're thinking, oh, this might be a metastasis. And that's why these lesions are biopsied. So this is the characteristic look. And as I said before, you get these interstitial mixed inflammatory infiltrates, and the only thing you get within the air spaces are these smokers macrophages with this brown pigment in them. Here I've shown you all the look of these various Langerhans cells. Here's an example, for example. See how convoluted and twisted the nuclei are, and just like Rifat mentioned, there are eosinophils along with that within the interstitium in a myxoid background. Here's an S100 stain that shows positivity within these Langerhans cells. Here's a CD1A, exactly like the case I just showed you. And remember, this is Langerhans, not Langhans. Langerhans giant cells are seen in granulomas. Langerhans cells are named after Paul Langerhans, who was a German pathologist. So here's a quick fun thing for you guys. How is smoking related to Langerhans cell histiocytosis? So here's my little cartoon on that. Alright, so you smoke, and do you guys see that little brown dot in the trachea? Do you guys see that?
Yeah.
So that brown dot is meant to indicate cigarette smoke. So follow it down. It goes down the trachea. You're smoking. It's going down into the bronchi of the lung, further down, and ends up within the smallest bronchioles in the lung. So cigarette smoke is being inhaled into the small airways. Then it goes into, what structure is this? Anybody at St. Luke's? What structure is this little thing here? A bronchiole. What kind? Anybody at SUNY Upstate? What particular kind of bronchiole is this bronchiole? This is a respiratory bronchiole. A bronchiole that merges into the alveoli. So this is the last portion of the bronchiolar system before bronchioles turn into alveoli. And you've seen that now the dust accumulates in this area, and then macrophages in the lung come and see this dust. Guess what they say? Yum. Cigarette dirt. So these macrophages then eat up this dirt, and that gives us the typical feature that we call respiratory bronchiolitis, which is simply macrophages that have eaten up this cigarette dirt and are present in the air spaces. This is a marker that the patient is a cigarette smoker. That's all its significance is. But then what, and here I'm showing you an iron stain in a patient who has hemosiderin in his macrophages versus a patient who has cigarette smoke in his macrophages. So you see, it does stain with iron, but it's a very light stain, lighter than true hemosiderin. So this macrophage dirt that has come from the cigarette smoke goes into the interstitium. And as these macrophages enter the interstitium, the cells of the immune system begin to respond to that, because they sense that it's like a thief coming into the interstitium and entering in an illegal way. And the guys who raise the bugle are the Langerhans cells. So these are the sentries, the guys who say, look, there's a robber there. And these guys then invite other cells, which are the effector cells, which are mostly eosinophils, lymphocytes, other kinds of effector cells. And so you have these sheets and sheets of Langerhans cells in the interstitium mixed with other effector cells, all triggered by the presence of cigarette smoke within the lungs. And here I am showing you again several Langerhans cells within the interstitium, as well as several eosinophils there. And all that action happening at high magnification is what gives you this low magnification look of a stellate nodule. And that's why you get these little multiple bilateral nodules in the lung in Langerhans cell histiocytosis. So if you move one step back, that's why you get this radiologic picture in Langerhans cell histiocytosis, which is so disturbing and mimics the appearance of a metastasis or a fungal infection. Now, interestingly, if you stop cigarette smoking, all those abnormalities can spontaneously regress and become completely clear. So on the left side of the field here, you see a patient with Langerhans cell histiocytosis. And on the right side, you see a couple of months later after stopping cigarette smoking, and you can see virtually all the abnormalities have disappeared and all the lung nodules have gone away. So this is not a tumor. This is simply a reactive proliferation of Langerhans cells in response to cigarette smoke, and goes away with cessation of cigarette smoking. So that is really the only effective treatment for Langerhans cell histiocytosis. Again, shameless plug for my book, because that's another place where all these things are described. All right, guys, any questions from St. Luke's?
Actually, this case gave us a lot of headache, to be honest. And I don't know, so we kept thinking of a lot of things here and there, but at least okay. So it turned out to be LCA, so that's great.
Yes, yes. And the next time you guys see a case like this, you'll know exactly what to look for and what stains to do. Any cases from SUNY Upstate?
No.
Any questions? Okay, great.
It's a very nice presentation.
Thank you, Ola. Any questions from Paul?
No, we're all set. Thanks.
All right, great. Thank you guys very much for attending. We're going to stop it here. Thank you very much, Rifat, Emilio, and all the rest of you guys. Before we end, I'll just make a plug for the website of the St. Luke's Roosevelt residency program. It's just a fantastic website. Everybody who's watching on Periscope and worldwide should go and check it out. These guys have done a great job. Thank you guys for having me. We're going to end the presentation now.
Baby and Sham is trying to help
Yes.
so they are both like there, and it's Emilia's thing. So all credit to Emilia, don't give to all of us.
Okay, great. Thank you guys. Thank you very much for coming. And hopefully we'll post this stuff on YouTube down the line in a few days.
Sanjay, that's correct. So what is the diagnosis for case 8? We thought of some fungus or maybe mycosis or oxygen.
Yes, so case 8 was actually a case of fibrosing mediastinitis. So all the fibrosis that you were seeing, the collagen deposition, was simply just scarring and collagen that you see typically in a subcarinal location. The clue to the diagnosis was a little fragment of necrosis in the center, and I'd shown you the GMS stain. That fragment of necrosis actually contains histoplasma, very rare histoplasma organisms within it. So it's actually a very, very difficult diagnosis to make, but I gave you the GMS stain to show you that sometimes you can have pieces of necrosis or necrotizing granulomas with histoplasma in them, which can be a clue to the diagnosis. So fibrosing mediastinitis.
That's a really great session for all of us.
Okay, great. Thank you very much. Thank you for attending.
Thank you.
See you. Thank you very much, Ola. Thank you. Thanks, Ola and Paul, and everybody on Periscope. Thank you very much for attending. We're going to stop the broadcast now.
Can I have a last question, Dr. Sanjay?
Yes, please. One more question? Yeah.
So the last case I'm supposed to present is, so besides fungal infection, what else differential you think? Such as I'm thinking about like some sort of vasculitis, like Wegener's. It's not typical, but there's some like...
For the last case, for fibrosing mediastinitis?
Yeah, like what else differential like?
Wegener's I would not, because typically it does not involve the subcarinal or mediastinal area. I would think of other infections. For example, tuberculosis can give you fibrosis of that kind. But the thing that you should be keeping in mind when you get a mixed inflammatory infiltrate and fibrosis in the mediastinum is Hodgkin's lymphoma. You want to make sure you're not missing a lymphoma. So before you make the diagnosis of fibrosing mediastinitis, make sure that you have excluded a malignant diagnosis before you jump to that conclusion. Hypersensitivity is not in the differential because it does not cause mediastinal lesions. It's a lung parenchymal disease.
Okay, good to know. Thank you so much.
All right, guys, take care. Thank you very much. We're going to end the Periscope presentation.
Thank you.
Thank you.